by dotatate, or what's your experience about that?
It depends. It depends. You know, I think oftentimes, as you kind of mentioned, there's heterogeneity in these tumors. And I think that dotatate is often more sensitive than many of the other imaging modalities we have, but it's not perfect. So, you know, if you feel this patient has a neuroendocrine tumor, regardless which one, I mean, it could be a paraganglioma, doing dotatate PET-CT may help you. It may help you detect something that you otherwise were not able to, but it's not perfect. I think that, you know, our sensitivity continues to improve, but it's not guaranteed we're going to see it. But I think for many patients where you haven't been able to detect the lesion, you move to the dotatate PET-CT, now you are. So it's going to change the management in some, not all. It's not 100%.
Any other question? Okay, please proceed for the next talk on sarcomas and cutaneous lesions, please.
All right, well, thank you guys very much again. So this topic is, there's so many sarcomas and so many cutaneous malignancies that we're just touching upon some here. I've highlighted this paper, if anyone wants to read more in depth, that has actually Dr. Salem on it as well, Dr. Covington, myself, and Dr. Morton, and the images from this study, or from this, are in that paper. This is my disclosure. And we're going to go fairly quickly because this is a pretty large topic. So PET-CT in primary cutaneous malignancy. The three most common non-lymphomatous aggressive cutaneous malignancies in which PET-CT plays a role include malignant melanoma, cutaneous squamous cell carcinoma, and Merkel cell carcinoma. PET-CT is particularly advantageous in the presence of distant metastatic disease or its response to treatment. We typically do head-to-toe imaging because these can be widespread, and we can see it all in PET-CT. There are a handful of important considerations. Hypermetabolic skin lesions can be difficult to appreciate on FDG PET-CT if thin. And so there's something called non-attenuated correction imaging. That can be really, really useful, especially looking at the skin surface. Focal metabolic activity in the skin can result not only from skin cancer, but anything inflammatory. So even if someone has acne, that can be hypermetabolic. So you can have skin trauma, you can have active skin formation. That can be a limitation for us, but we can still identify a location that the clinician can then go and examine that patient. Evaluation of the surgical bed for a residual tumor is often difficult because that surgical bed is going to be inflammatory. It could be scar tissue, it could be anything that's going to have uptake too. And our ability to differentiate that uptake being tumor versus something inflammatory can be limited. We can't assess very well the depth. So the depth of the tumor is not well assessed by FDG PET-CT. And so surgical pathology, working with your pathologist, is still critical. I don't know how much checkpoint inhibitors and immunotherapy is being done here, but if it is, and I suspect over time it will be, the development of systemic inflammatory immune-related adverse events is something that you need to know and need to be familiar with. That can affect your ability to determine whether this is disease or whether it's related to just the treatment itself. So you can see sarcoid-like lymphadenitis, hypophysitis, cerebritis, focal or diffuse lung opacities due to pneumonitis, hepatitis, pancreatitis, colitis, many, many different things. And typically where you know your tumor is, that can be indicative that it's working. So that tumor itself can actually improve. While you see a lot of things elsewhere related to the immunotherapy, your tumor itself can be improving. This is just an example here. So here you can see this patient has their melanoma in their right temporal region. This is before they got their immunotherapy. This is called the maximum intensity projection image. Looks pretty clean outside of here. After they started their immunotherapy, what do you guys think? So you can see the lesion here. And then you see all this adenopathy that wasn't there before, okay? They stopped their therapy, it went away. So this wasn't actually disease. They weren't progressing. You need to understand that there can be an immune-related adverse event. This is same patient. Here you can see their primary tumor, received their treatment, and now you see this hilar adenopathy. This is not disease. This is actually with immunotherapy. When it stopped, it went away. So we have this term called pseudoprogression. It's development of relative increase in metabolic activity in known sites of tumor involvement. Most commonly we see it in melanoma, but it can be in others too. One thing you want to consider is that, okay, assess the patient. Are they in tumors looking big, a month or two where you see that stuff? So if you wait a while and then repeat, oftentimes it can be better, and it can be worthwhile to do that before discontinuing treatment. So melanoma, it's an aggressive melanocytic neoplasm, and it's increasing in frequency. It's fifth most common in both men and women. There's both epithelial or cutaneous and non-epithelial or non-cutaneous. The non-cutaneous melanoma comprise only 7%. So the majority of these patients actually are cutaneous. And 75% of the non-cutaneous are ocular. This can have a very, very poor prognosis. Cutaneous is the minority of skin cancers, but the majority of skin cancer-related deaths. It's markedly increasing in frequency, and survival in most cases depends on the depth of the lesion, which we call the Breslow depth. Treatment is typically by Mohs surgery and wide excision, and often is combined with sentinel lymph node biopsy for lesions greater than 1 millimeter depth. First-line treatment for widely metastatic disease is often a combination of targeted and immunotherapeutic approaches. So we typically perform a sentinel lymph node biopsy, not us, our team, as radiology. Well, it depends. In certain circumstances, the radiologist could do the biopsy. And you do it for primary lesions with a Breslow thickness of greater than 0.8 to 1 millimeter or less than 0.8 millimeters if you see ulceration. False negatives can occur with lymphoscintigraphy. So oftentimes lymphoscintigraphy is done where sulfur colloid is injected, and that can be those patients particularly with poor lymphatic clearance of injected tracers and those with ulcerated or thick primary lesions. FDG PET-CT can be extremely beneficial for staging and defining the extent of its advanced metastatic disease. And it's typically intensely hypermetabolic, which can be quite useful because we can really identify small lesions. So the National Cancer Care Network, or NCCN, this is a United States network that gives recommendations. They endorse FDG PET-CT at the outset for stage 3 or 4 disease. And they acknowledge that it may be more sensitive than other modalities, particularly for the extremities. We scan from the top of the head through the feet, and it can make a huge, our sensitivity of detecting things, especially for stage 3 and 4 disease, is quite good. So 68 to 87% with specificity of 92 to 98%. So this is what's typically done for sentinel lymph node localization. The patient receives technetium-99 sulfur colloid. The sulfur colloid is usually injected around the primary lesion. And so you can see here on the planar imaging, this is where it was injected, and you can see the tracer going to the axillary nodes here. And this is kind of the same thing. This is where their primary lesion was. You can see these axillary nodes. And that's oftentimes gets the lesion, but as I said, it's not always the case, and I'm showing you a lecture that includes FDG PET-CT. So this is a case where, if we go back here, they had this lymph node right here. You see that one? It didn't take up the tracer. So in this patient, the lymphatic drainage didn't identify it completely, but the FDG PET-CT picked up this malignant lesion quite well. So FDG PET-CT can be really helpful, even in cases with sentinel lymph node localization. This is a case of melanoma of the right ear, metastatic to the skin and multiple regional lymph nodes. So this is just an example of just how beneficial and helpful this can be. So here you can see the primary lesion. You can see it draining down into the skin, into the parotid lymph node, into level 2, into level 1B, and even tiny supraclavicular nodes that turn out to be malignant that without this you may or may not be able to detect. So this can really change our ability to see where there's disease and help really manage these patients. This is a case where this patient had a resection of a lesion and they had a seroma post-resection, so you can see that right here. They had an inguinal node that was positive, and here this tiny little nodule turned out to be the primary lesion. So in the posterior right thigh here, they were able to identify that primary lesion, and FDG PET-CT helped make that possible. This is another lesion that just shows melanoma of the left lower leg and metastatic to the lower extremity. So you can see this really intense uptake extending to the skin surface. You can see the skin edema. Here's this exophytic lesion that happened to be the primary lesion, and you can really detect the extent of disease quite well. This is called the maximum intensity projection image, and the intensity of these lesions is quite high, so we're able to detect even quite small lesions. Okay, so for Merkel cell carcinoma, it's an aggressive primary neuroendocrine skin cancer, often evades early diagnosis. It's rare. Most occur in the elderly in the periorbital region in areas of solar skin damage or sun damage. Treatment is by wide excision and adjuvant radiation. Nodal dissection performed when lymph node involvement is present, and chemotherapy is often added when distant metastases. The disease ultimately progresses. With distant metastatic disease, it's essentially fatal at this point. Sites of involvement are typically strongly hypermetabolic, so we can oftentimes really detect where it is, and it can alter the stage, FDG PET-CT, in a very, very large number of these patients. Immune checkpoint inhibitors have shown promise in clinical trials for Merkel cell, and FDG PET-CT has been used successfully as an imaging marker of response. As we talked about just, 20 minutes ago, we were talking about neuroendocrine tumors. Merkel cell happens to be one. And in that way, the somatostatin receptor imaging has been reported to be effective in these patients, with similar performances to that of FDG PET. So here's an example of metastatic Merkel cell carcinoma, where we can really detect pretty small lesions. Here you can see multiple deposits in the right pleura. And then you can also see this lower pelvis lesion right here, and this is the large primary tumor extending to the skin surface and subcutaneous tissue of the right buttock. And so we can really assess the extent of disease and detect pretty small lesions with FDG PET-CT. This is another case. This is more typical. You'll find, so here's our primary tumor in the right temporal region. You can see multiple lesions in the liver, a cardiophrenic node. You can see a large portocaval metastatic lesions and a small right retrocrural node. So we can identify pretty small lesions with FDG PET-CT. Cutaneous squamous cell carcinoma is the second most common dermal malignancy after basal cell carcinoma. It's linked again to sun exposure. So wear your sunscreen, wear your hats, try not to get too much exposure. And it's also been linked to immunosuppressive drugs, so patients that are on immunosuppression are more susceptible to developing these. Treatment's typically by surgical excision and Mohs surgery. If you can treat it early, the overall survival is quite good, greater than 90%. But when lymph nodes involved, that 5-year survival drops dramatically. Prognosis is affected by the size and thickness of the primary tumor, desmoplastic growth, and immunosuppression. Again, metastatic lesions of these are typically quite strongly hypermetabolic on FDG PET-CT. In series of patients with squamous cell carcinoma of the head and neck, which we do typically at Utah, the sensitivity and positive predictive value is extremely high. It's been viewed to be about 100%. And so for the primary lesion, 100%. Nodal disease is less so, meaning we can see small nodes that are hypermetabolic. They may be diseased, they may be due to an inflammatory process or something else. So inflammatory or reactive nodes can be sources of potential false positives. The NCCN endorses the use of FDG PET-CT in the initial evaluation of nodal basin assessment for radiation treatment planning and to rule out distant metastases. At the moment, it's been reported to not significantly change management, and that's one debate for which patients should receive this. This is an example of a cutaneous squamous cell carcinoma of the skull vertex, so you can see it here. And it's actually eroding into the calvarium. Now, I know Dr. Salem mentioned before in the brain, we have so much metabolic activity in the brain that our ability to detect lesions in the brain can be limited. So in this sort of patient, you would want an MRI too. You want an MRI to really know, okay, what extent of disease is actually affecting the brain here. So we can see the erosion into the calvarium quite well, but to really assess the intracranial extension, you're going to want an MRI as well. Axial FDG PET-CT of the upper abdomen shows extensive hypermetabolic right pleural metastases, which you can see here. This is another example of multiple skin squamous cell carcinomas in a heart transplant patient. Here you can see a large ulcerated lesion in the right frontal scalp. Here you can see in the skin under the left jawline. And in the lower neck, you can see a third lesion right here over the posterior left medial shoulder, and a level 3 and 4 node that is also positive. So sarcomas, there are many sarcomas, and we're only going to touch upon some of them today. It represents about 2% of malignancies in adults and 10 to 15% of malignancies in children and adolescents and young adults. It arises from mesenchymal cells of various tissues. Two major categories of sarcomas. So we have soft tissue and bone, and we're going to touch upon some of both of those. MRI and CT are typically the imaging modalities of choice in sarcomas. Since the metastatic disease can occur widely, again, we're going to recommend head-to-toe imaging. So in PET-CT, you want to do head-to-toe in these patients. Most soft tissue and bone sarcomas are metabolically active on FDG PET-CT and can be more intense and aggressive tumors. The FDG PET-CT can be used in not just detecting the disease, but directing the surgeon or referring physician where to biopsy, and also in suggesting areas that may be transformed, and we'll try to show some examples. So soft tissue sarcomas, they account for approximately 1% of adult malignancies. There's more than 50 types of aggressive soft tissue sarcomas capable of metastatic spread, and to do 50 today, you guys will be here for quite a long time. It's been reported that a baseline maximum SUV value of greater than 6 or a decline of less than 40% are associated with high risk for recurrent soft tissue sarcoma related to neoadjuvant chemotherapy. After one cycle of chemotherapy, a reduction of less than 35% is predictive of a higher risk of poor histopathologic response. So undifferentiated pleomorphic sarcoma is one we're going to touch upon, previously called malignant fibrous histiocytomas. These typically arise in older adults. They can be male predominant, can arise at sites of prior radiation treatment, so someone that had radiation for something else. Most of the tumors are intramuscular in the extremity and torso. The NCN supports use of FDG, PET-CT, and staging. And treatment is typically wide en bloc surgical resection with limb sparing, if possible, followed by radiation. So here's our example of the undifferentiated pleomorphic sarcoma. You can see pretty intense uptake in the right trapezius muscle. And not only can you identify that primary lesion, but you can see this left hilar node with intense uptake, which is metastatic. Leiomyosarcoma, it arises from smooth muscle and are non-GI mesenchymal stromal tumors. It accounts for 7% of soft tissue sarcomas with an average survival of just 5 years. Non-uterine leiomyosarcomas can occur widely, including gut involving vascular structures. Most often occur in the pelvis and retroperitoneum. Surgery is usually the treatment of choice. Radiation therapy and chemotherapy can be employed, but typically are not very effective. Typically you do long-term treatment, long-term monitoring, and these patients their disease can change. So they can be stable and then suddenly progress. So this is just an example of leiomyosarcoma with late metastatic disease. Axial FDG PET-CT of the chest shows a hypermetabolic left breast mass, you can see here, and images of the thighs in both femurs show soft tissue masses extending into the femur itself. Angiosarcoma typically arises from vascular elements. In addition to the heart and large vessels, angiosarcomas can arise in many other organs, including the skin, lungs, bones, breast, liver, and spleen. Aggressive angiosarcomas can be intensely hypermetabolic on FDG PET-CT. Angiosarcomas of the heart or great vessels often metastasized by hematogenous spread. So this is just one angiosarcoma of the spleen with an adrenal metastases. And you can see the hypermetabolic splenic tumor with scattered areas of necrosis, and a hypermetabolic right adrenal metastasis is also present. This is a different angiosarcoma of the aorta with downstream hematogenous metastases. So here's our axial FDG PET-CT. You can see this crescenteric hypermetabolic lesion in the aorta. Here you can see on the contrast-enhanced CT here. And here you can see all the metastases distal to that primary lesion. So you can see all downstream from that primary aortic lesion. Here's one in the gluteus minimus with extension into the adjacent iliac bone. Kaposi's sarcoma, angioproliferative spindle cell tumor derived from immune and endothelial cells infected with HHV8 or human herpes virus type 8. It occurs in conjunction with HIV and in immunocompromised patients. Typically, you treat with heart or highly active antiretroviral therapy, and sometimes in combination with chemotherapy. There's evidence that FDG PET-CT can be used to monitor the effectiveness and treatment of HHV8 viral load. And multicentric Castleman's disease, which is also associated with this, can occur in HIV patients, and it can be difficult to distinguish between the two entities on FDG PET-CT. So this is an example of a patient with Kaposi's sarcoma. In this case, you can see plaques and nodules right here on the skin surface, and ill-defined. These are pretty ill-defined hypermetabolic lymph nodes. Rhabdomyosarcoma is the most common soft tissue sarcoma. It arises from primitive mesenchymal tissue capable of differentiating to skeletal muscle. The vast majority occur in children and young adults. It's more aggressive in older patients. Treatment usually involves surgery and radiation. Chemotherapy may be utilized as well in high-risk patients. It tends to be moderate in terms of metabolic activity on FDG PET-CT and has been shown to be effective as well as more accurate than conventional imaging in staging and restaging. So this is an example of nasopharyngeal rhabdomyosarcoma. You can see multiple axial FDG PET-CTs of the head and extensive nasopharyngeal rhabdomyosarcoma. It fills the ethmoid sinus, the maxillary sinus, extension into the nasal cavity and nasopharynx. The most common soft tissue sarcoma in adults, mostly arising de novo. A small number may arise from pre-existing lipomas. There's multiple subtypes, well-differentiated, myxoid and or round cell, and pleomorphic or dedifferentiated. The pleomorphic and dedifferentiated is primarily in the retroperitoneum and has an aggressive worse prognosis. Hibernomas, which are benign lipomas with brown fat, are often FDG avid, and those can be found incidentally. And distinction between hibernomas and low-grade liposarcomas we oftentimes can't make with FDG PET-CT, but it can help guide a biopsy. So it can help guide a biopsy to differentiate these two. Treatments, typically surgery and radiation. Chemotherapy may be of some benefit in patients with metastatic dedifferentiated liposarcoma. So this is an example of a hibernoma. You can see in this right paraspinal region here. You guys see the arrow with the mild uptake and a little bit of fat density, a little bit of stranding. We cannot well differentiate this from a low-grade liposarcoma. However, we can say this is a spot, and we can help guide biopsy or guide monitoring of it. This is, wait a minute, I skipped one, I think. There we are. So this is a low-grade liposarcoma. So here you can see in the right sartorius muscle, again, that really, really low-grade uptake. We wouldn't necessarily know definitively in this case what this is, but we can help guide, okay, we see this lesion. This could be a low-grade liposarcoma. It could be a hibernoma, and it can help guide biopsy. In this case, the biopsy turned out to be low-grade liposarcoma. This is a case where a liposarcoma, so a low-grade one, actually de-differentiated from a well-differentiated liposarcoma. And you guys may remember that the de-differentiated can be more concerning. And here you can see minimally, but more intensely avid uptake than part of the low-grade tumor. And it's eroding the anterior left chest wall, and it has a very, very aggressive sort of appearance. This is a myxoid liposarcoma of the central compartment of the neck. And here you can see a cystic tumor in the central compartment. And if MRI was done, you may see multiple loculations here. You can kind of make them out on the FDG PET-CT. And this really has that sort of multiloculated appearance. So synovial sarcoma are rare soft tissue tumors. They're advanced stage synovial sarcomas have a very poor prognosis. Almost all of the patients have a fusion of these SYT-SXX genes, and I'm not going to say this part here, but most of the patients have a fusion of this. They occur as spindle cell fibrous and glandular epithelial forms. They tend to occur around large joints, such as the knees and other areas, including the hands, feet, neck, pericardium, and pleura. Treatment consists of aggressive surgery, radiation, and in tumors greater than 5 centimeters, chemotherapy. Higher metabolic activity is associated with a worse prognosis. So here's an example of a synovial sarcoma of the left lower thigh. You can see a lobulated hypermetabolic mass arising from the synovial capsule of the left knee, and it contains a multilobulated cystic areas that dissect into the surrounding soft tissues. This is a case of a pleural synovial sarcoma. There are multiple hypermetabolic masses. Here you can see the left hilum, and here you can see the left pleural space. And again, they're multiloculated, and we can really identify quite well where these tumors are on FDG PET-CT. Bone sarcomas, we're going to touch upon some, including chondrosarcoma, osteosarcoma, and Ewing sarcoma. And then we're going to finish this topic off. They all can metastasize to bone and soft tissues. So chondrosarcomas are cartilage-containing tumors, classified as low-grade, intermediate, or high-grade, or de-differentiated. They can arise de novo. MRI can be utilized for evaluation. Myxoid chondrosarcomas arise from soft tissue rather than bone. Biopsy can be performed, but may be inconclusive. Treatment of presumed low-grade is typically curettage with complete surgical resection of presumed higher-grade lesions, and radiotherapy and chemotherapy may be used when lesion is unresectable. Chondrosarcoma and chondromas may have no activity or may be mildly metabolically active, and that can be hard to differentiate an enchondroma, which is benign, from a low-grade chondrosarcoma. NCCN typically endorses FDG PET-CT in staging conventional poorly differentiated or de-differentiated chondrosarcomas, and it's been reported that higher SUV values, so greater than 4.4, predicts a higher grade chondrosarcoma, and with really high sensitivity. So these are benign enchondromas. We typically describe what people say will sometimes be ring and arcs. However, they can have low-grade metabolic activity. And one thing that can be challenging is enchondromas can actually become malignant. And one thing that oftentimes you want to do is promptly evaluate these patients if they develop new onset of pain. So if they've been having no symptoms for a long time and suddenly they're developing new onset of pain, that can be concerning that this is actually changing. Osteosarcoma, it's a bone cancer that typically arises in the distal femur, proximal tibia, and proximal humerus of adolescents. You can also see it in the skull, jaw, and pelvis. Most cases don't have a known cause, although certain conditions, patients are at higher risk. That includes Paget's disease, fibrous dysplasia, and enchondromatoses, including multiple hereditary